To do this, we're going to follow a clear roadmap. We'll start by comparing adult and fetal wound healing, cover the early stages of hemostasis and inflammation, and then map out the late stages of proliferation and remodeling. After that, we'll shift gears to look at specialized mechanisms for bone healing, peripheral nerve regeneration, and tendon repair and mobilization.
Okay, Section 1, Wound Healing, Adult versus Fetal.
Let's dive right in by establishing our fundamental biological baseline for how tissue responds to injury. Before we map out the timeline, we have to talk about a really critical biological paradox. There's a stark contrast in our physiological capabilities depending on our stage of development. For us adults, across literally all organ systems, the body naturally defaults to fibrosis and scar formation. Sure, this closes the wound, but it ultimately causes a degree of tissue dysfunction simply because scar tissue is never as functional as the original tissue. But if we look at early gestation fetal tissue, it possesses this remarkable biological ability to heal completely scarless, no fibrosis whatsoever. The tissue is perfectly regenerated. So understanding adult wound healing means understanding a process that prioritizes speed and closure over perfect structural regeneration.
Moving right along to Section 2, Early Stages Hemostasis and Inflammation. Let's look at the linear timeline of adult skin healing.
We're starting at the exact fraction of a second that physical trauma occurs. The entirety of the tissue repair journey is structured by 4 chronological stages. First, we have hemostasis, which happens immediately. Then, inflammation, spanning days 1 to 3. After that, proliferation, which runs from day 3 out to roughly 2 to 4 weeks. And finally, remodeling, which is a massive long-term process starting at week 2 or 3 and lasting a year or more.
So let's start with stage 1, hemostasis. This is a brilliant, immediate survival mechanism. Step 1. Endothelial disruption instantly triggers vasoconstriction and exposes the subendothelial extracellular matrix. Step 2. Platelets immediately adhere to this matrix. They activate and they release what are called alpha granules. These granules are absolutely packed with vital growth factors, like TGF-beta, PDF, FGF, EGF, and VEGF. And these are crucial because they're going to drive everything from extracellular matrix deposition to angiogenesis later on. Step 3. Tissue factor is released, which initiates the coagulation cascade. And finally, Step 4. This cascade generates thrombin, which acts like a biological glue to create a stable fibrin clot, sealing the breach. Concurrently, a slower process called fibrinolysis actually activates in the background, converting plasminogen to plasmin to eventually clear out this very meshwork.
Once the bleeding stops, we transition into Stage 2, cellular inflammation. This spans days 1 to 3 and essentially bridges our innate immune defense with tissue rebuilding. In the early phase, so days 1 and 2, platelets in injured tissue release histamine and serotonin, drastically increasing vascular permeability. This throws the doors wide open for neutrophils to flood the site and prevent bacterial contamination. Then, in the late phase, around days 2 and 3, we see a critical shift. Monocytes arrive and differentiate into macrophages. You can think of macrophages as the master orchestrators of healing. They phagocytose debris, release proteolytic enzymes, and pump out the cytokines needed to drive fibroblast proliferation and angiogenesis in the very next phase.
And this beautifully illustrates how microscopic cellular actions translate directly into the symptoms a patient actually experiences. Because of the vasodilation and increased vascular permeability caused by histamine and serotonin, fluid and cells physically rush into the tissue. This physiological shift translates directly into the 4 observable cardinal signs of inflammation: rubor, which is redness; tumor, meaning swelling; calor or heat; and dolor, which is pain. It's not just random discomfort, it's literally the visible result of the cellular repair machine switching on.
Right, on to Section 3, late stages, proliferation, and remodeling. What's really fascinating here is how the body successfully shifts from clearing out debris and fighting infection to actually rebuilding the compromised structure. Welcome to the proliferation phase, running from day 3 up to about 4 weeks. The cellular workforce here is dominated by fibroblasts. They get right to work producing ground substance, specifically glycosaminoglycans and proteoglycans, alongside early collagen. This forms what we call granulation tissue, which looks kind of pink and granular to the naked eye. At the exact same time, a specialized subset of cells called myofibroblasts activate. These cells are incredible. They possess contractile properties, and they perform the vital mechanical action of literally contracting to pull the wound edges closer together, shrinking the total surface area that needs repairing. Finally, the tissue enters the remodeling phase. Now, this is a drawn-out maturation process that can easily last a year or more. During this time, the quick, hastily laid down type 3 collagen
is methodically replaced by much stronger type 1 collagen. The body continues this molecular swap until the standard uninjured skin collagen ratio of 4:1 is fully restored. On top of that, this collagen undergoes extensive cross-linking and starts to align uniformly along lines of tension, which drastically increases the structural integrity of the scar.
So, what does this all mean for the patient? It comes down to one absolutely crucial threshold: 80%. Despite months of methodical cross-linking and collagen replacement, adult skin healing has hard limits. At 12 weeks post-injury, the tensile strength of the healed wound officially peaks, and it peaks at roughly 80% of its original pre-injury tensile strength. Sadly, it never fully regains its pristine mechanical properties.
Okay, let's move to Section 4, Mechanisms of Bone Healing.
Now we're going to apply these core principles to specialized systemic tissues, starting with the skeletal system. Bone healing is pretty unique because it's completely dictated by mechanical stability. If a fractured bone is placed under absolute rigid stability with direct edge apposition, which is the exact goal of open reduction and internal fixation, or ORIF surgery, it undergoes primary healing. This uses direct intramembranous ossification to unite the bone, meaning there's absolutely zero callus formation. Conversely, if there is non-rigid stability, like the kind you get with a standard cast, the bone undergoes indirect healing. This triggers endochondral ossification, which is a sequential process that relies heavily on forming a biological callus.
Let's trace that step-by-step causal pathway for indirect bone healing. It actually starts a lot like skin repair. A fracture hematoma, or blood clot, forms at the break. Next, this clot is swapped out for a soft callus made of fibrocartilage. Then, through end-control ossification, that fibrocartilage is converted into a hard callus made of woven bone. Finally, we hit the remodeling stage. Specialized cells, osteoclasts, which break down bone, and osteoblasts, which build it back up, work together over months to remodel that woven bone into highly organized, structured lamellar bone. But keep in mind, any significant instability during this process can easily cause a delayed union, a non-union, or a malunion.
Next up, Section 5, Peripheral Nerve Regeneration. We're shifting our focus to a really delicate, highly complex physiological process: repairing a physically injured peripheral nerve, a trauma clinically known as neurotemesis. Nerve repair actually kicks off with a destructive, but absolutely vital prerequisite clearing mechanism called Wallerian degeneration. When a nerve is severed, the section of the axon and myelin distal to the cut, meaning further away from the central nervous system, completely breaks down into debris. Proximally, however, the degeneration is highly controlled. It halts cleanly at the nearest node of Ranvier. This targeted destruction is essential because it clears the path for new growth.
Once Wallerian degeneration is triggered, an amazing cellular teamwork sequence begins. Step 1. Schwann cells recruit macrophages to the site to physically clear away that resulting axon and myelin debris. Step 2. Those same Schwann cells begin to heavily proliferate within the basal lamina. Step 3. These proliferating Schwann cells literally align themselves to construct physical guide rails known as bands of Bungner. Finally, Step 4. The newly sprouting proximal axon uses these bands of Bungner to navigate. It relies heavily on neurotropism, meaning it's chemically attracted to its correct target tissue by specific growth factors and extracellular matrix signals.
But there's a crucial clinical correlation we have to mention here. This neurotropic guidance system is incredibly fragile. If the regenerating axon gets disorganized, or if the protective paraneurial layer of the nerve was directly injured and breached, the axon fibers can tangle and bundle up right outside the intended pathway. So instead of functional nerve restoration, the patient develops a neuroma, that is a highly sensitive, severely painful mass of disorganized nerve tissue. Definitely not the outcome we want.
And that brings us to Section 6, Tendon Repair and Mobilization.
For our final specialized tissue, we're looking at tendons. Tendon healing is tricky because it has to perfectly balance two things: restoring immense structural tensile strength while maintaining smooth, unhindered mechanical gliding against surrounding tissues. It's essentially a battle between two competing biological mechanisms. First, the intrinsic mechanism. This relies on the tendon's internal vincular blood flow and diffusion from synovial fluid to heal the tissue from the inside out, which beautifully keeps the outer surface smooth. Second is the extrinsic mechanism. This heals the tendon very rapidly by forming external fibrous adhesions between the tendon and its surrounding sheath.
While extrinsic healing brings fast cellular support, those fibrous adhesions literally tether the tendon down, restricting its ability to glide and ruining its mechanical function.
Because of this biological tug-of-war, the clinical management strategy for tendon repair is very specific. The golden rule? Early active mobilization. By getting the patient to move the tendon shortly after injury, the mechanical gliding physically breaks up those restrictive extrinsic fibrous adhesions. This forces the body to rely on the advantageous, smooth, intrinsic healing pathway. However, because intrinsic healing relies on slower internal blood flow and synovial diffusion, the tendon remains structurally weak for a much longer period. Therefore, this early mobilization absolutely must be paired with careful, highly specific splinting. This protects the tendon and prevents a complete mechanical rupture before the structural integrity has fully returned.
So, we've seen how adult tissue brilliantly manages trauma, from forming fibrin clots and orchestrating macrophage responses, to building calluses, guiding axons, and balancing tendon mechanics. But it always relies, to some degree, on fibrosis and scarring. I want to wrap this explainer up by having you consider the future of medicine. Knowing the exact chronological constraints and cellular mechanics of adult healing, how close are we to unlocking the pathways that allow early fetal tissue to perfectly and completely regenerate? What biological mechanisms must we uncover to turn off adult scarring and turn on flawless physiological regeneration? Think about that as you review these mechanisms. Thanks so much for joining me on this deep dive.